gotta do this. Okay.
It's the whole module, right?
Whole module. Whole module. That's right. All you're gonna be thinking about is cardiac.
On
after
the
today.
video, there did, we didn't talk about the heart blocks. Only some of the.
You did? Yeah, you did. You only need to know the first and third. Thank God. You don't need to know the second three.
Okay, that's the other ones that I.
You didn't do it? I swear he did. You sure?
He did it at the end.
I knew you probably ran out of
Everything
time.
else, I was like.
That's right, that's right. We'll talk about it today, but yeah, if you have trouble with it, scroll to the end of that video. Strong work. Thanks for saying that. Okay, so patient presentation number 2. 45-year-old female patient presents to the ED with chest pain. Uh-oh. That's gonna be like the classic answer. Heart failure. She describes the pain as fairly constant, but is worse with deep inspiration and when she lays down. Let me read that again. She describes the pain as fairly constant, but is worse with deep inspiration and when she lays down. Okay, so upon auscultation, the RN hears a scratchy friction rub near the left lower sternal border. Patient complains of some dyspnea. Patient has a history of HIV and had a permanent pacemaker placed after her MI 2 months ago. Wow, a lot of information in a short paragraph, you guys. Vitals, heart rate of 118, high, lower, normal. High, excellent. Blood pressure 112/81 with a map of 72. Do we love that map? Absolutely, it's fine, right? End organ perfusion, check. Respiratory of 31. A little bit high, right? Temp of 38 degrees Celsius. Okay, a little bit high, so a little bit of a fever, okay. O2 sat of 95% on room air. Okay, right? It's not amazing, but it's okay, right? So we know, okay, when looking at her vital signs, what do you think is driving most of those vital signs? The pain, absolutely. Great job, you guys. Absolutely. Okay. So that heart rate, 118, a little bit higher than, normal, right? And then respiratory of 31, absolutely. Okay. And then that temperature, ever so slightly, very, very low grade fever, right? It's probably what's driving maybe that she has a lower stat on room air. Okay. So right away, first sign, you see chest pain. What automatically do you think besides heart failure? What? Heart failure. It's gonna be like the token. Please don't answer all the questions, heart failure. Okay, so I heard something, pericarditis, but if you didn't think that, that is the correct answer. If you didn't think that and you saw chest pain, what do we all always think? Right? Absolutely. Okay. So what I need you to notice, okay, yes, chest pain is absolutely something that happens when people have an MI. But the sentence I read twice, right? When I repeat things, oftentimes it's important, right? So the patient describes the pain as fairly constant, right? Fairly constant. So right there, that should have some bells go off in your head because it's describing the quality of the pain. Okay, and then she also says it gets worse. What makes it better? What makes it worse, right? It's worse upon deep inspiration, so when she takes a deep breath, right? And then when she lays down. So what is that telling us about this particular chest pain? It's positional, right? It's positional. Depending on what she's doing, where she's laying, it is positional, okay? That's important. Is usually an MI pain positional? Absolutely not. It's constant. It's constant. It's crushing. Nothing alleviates it. Okay? So again, right away, if you're like, oh, I know this MI, think again. Read through everything, right? I mean, she had a history of an MI. Sure, she could be having another one. But again, pay attention to the chest pain. It's important. Okay? All right. So, yes, ma'am.
Does MI chest pain get worse with anything?
It can probably just get worse. It's not like you do something to make it worse.
Yeah.
But yes, it can become more painful, more suffocating, more crushing. Absolutely. Despite you resting, despite the nitroglycerin. Okay? All right, so in looking at that, given this patient's presentation, right, what do you think is going on? What's this disease process? And then how can you confirm your diagnosis? Okay? So again, you guys, right? Think about what we're doing. We're diving in, we're looking at symptomology, right? And then we're talking about diagnostics. And then afterwards, we talk about medical management and nursing intervention. This is how you should be studying. Okay? All fair game for your exam.
She had a history of an MI or no?
Yes, ma'am. Okay, so you guys are right on the money, okay? We are looking at pericarditis. Now, if you look back at the symptomology, okay? Symptomology, so if you don't even think about, let's say chest pain out of this, right? The hallmark sign is that scratchy friction rub near the left lower sternal border. That should be the bells going off in your head that's alerting you to pericarditis, okay? That friction rub. Now, it's pretty hard. I think I've heard it once in my entire career, and that's because the physician put my stethoscope where to listen, and then I heard it, okay? It's harder to hear. It's not something that's very obvious. Maybe I'm just terrible at listening to things, but I don't think it's hard. Again, oftentimes though, they are going to be coupled with some sort of chest pain. The take-home message with this chest pain is that it is positional, okay? It is positional. It's worse laying flat. Okay, it's worse laying flat and deep inspiration, okay? Taking a deep breath makes it worse, okay? The other thing to make note of is that she had an MI 2 months ago with a permanent pacemaker. Why is that history important to pericarditis? What do you think?
Infection.
What do you say?
Possibly introduce infection.
Absolutely, yeah, totally. So the integrity of the pericardium was poked through. Okay, the integrity was compromised. Okay, I was trying to think of what the word was. The integrity was compromised because she had a permanent pacemaker placed. So Alex, you're right on the money. I don't think they did it on purpose, but somehow some sort of infection was introduced. Okay, so we can look at pericarditis, right? Again. Make it make sense, right? So we have the pericardium, that's what we're talking about. It's the outer layer of the heart, right? The outer layer of the heart, that sac essentially, okay, that's holding the heart. And itis, right? Inflammation, okay? Does anybody know how many cc's are in that little sac, that pericardium? Anybody know? No? 50 cc's. So you take this syringe, and there's 5 of them, okay? Everybody see a 50 cc syringe at the bedside? Okay, it's not very much, okay? That's not very much fluid, okay? That's there. But when we have pericarditis, you're certainly at risk for more fluid to accumulate, right? Having to do with the inflammation process. So, how do we diagnose this? Interestingly enough, oftentimes pericarditis is made solely on the basis of history and signs and symptoms. History and signs and symptoms. Yes, absolutely. The pictures that you would utilize is a CT or an MRI. What do you think is quicker, CT or an MRI? CT. Okay, absolutely. MRI, usually there's not many machines in the hospital, right? Sometimes people don't even have an MRI machine. And it's the picture, the test takes a lot longer. CT, in and out, okay?
Like the X-ray, it's just X-ray that might show enlargement or
It could, yeah, absolutely. I would venture to guess that that would be your first thing that you might do, but then you would want a little bit more of a detailed picture with the CT, but great thinking, I like that. So first diagnostically at the bedside, you could shoot an X-ray and then, hey, something looks weird, let me go ahead and get a more detailed picture like a CT, okay? But again, remember guys, diagnostically, oftentimes people are describing this, they have that hallmark sign of that pericardial friction rub, and that's telling us that this patient has pericarditis, okay? Questions about this? Okay. So, what medical management do you anticipate? What nursing interventions should you perform? And then, just like everything else, okay, you being that proactive, astute nurse, what kinds of complications do you think? Okay? I still do this day, guys. Every time I come into the bedside and I have a patient or two patients, I kind of want to die, but one patient, right, I always think to myself, what's the worst that can happen? Obviously, the worst that can happen is that they could code. But even if that is the case, what am I going to do about it, right? I think through these scenarios in my brain. That way, when it happens, because you better believe it's going to happen, I have a plan in my head and I'm not flapping around scrambling. Okay? I love it. Strong work. Okay, so like we just talked about, right? The chest pain that that your patient is experiencing is positional. Okay, it is positional. So you're going to have to teach your patient how they should be positioned in bed. Okay, you walk into the room and Mrs. Smith, she's laying flat on her back, right? And she's moaning and groaning, and she's like, "I'm in so much pain." You're like, "Ma'am, let us sit you up." Okay, let us sit you up. If you sit up more towards, 80 to 90 degrees, you will have less pain. Oh, let me grab the bedside table. Table. You can lean forward on it because sometimes leaning forward can help relieve that pain. Okay? So again, we have some itis, right? We have some inflammation. So what kind of pain management do you expect? I see it on here, but let's name some drugs. We have pharmacology. Oh, I see it. NSAIDs, corticosteroids. I love it. So things that are going to help with that inflammation, right? So NSAIDs, that's going to be huge. Corticosteroids, right? Pain assessment and making sure you are teaching your patient, hey, please don't lay flat. That's not going to help you. You have to sit up more. Maybe we need to put some pillows behind your back, okay? Maybe you need to lean on that bedside table, okay? Now, I love that you guys put this. I'm just intrigued by it. It says, monitor for signs of decreased cardiac output. What the heck does that mean? Why would I be concerned about that? Okay, so hypotension is a sign that you would be looking for. Okay, so think about the pathophysiology of what's happening with pericarditis, right? I Now, if we know that there's inflammation happening there, right? How much do you think it could accumulate in that space? What do you think? How many?
More than that.
Okay, more than that, take a guess. Take a guess. What do you think? 100 cc's? 500? A liter? What do you think?
Yeah.
Yeah, absolutely. There's a lot of fluid that could happen, that could accumulate in there, okay? Depending on what kind of inflammation is happening, okay? That's part of the inflammatory process. So if you can imagine 50 cc's, that's like a lubrication kind of situation, right? Because again, it's the sac that's holding the heart, so that's helping the heart being able to pump effectively, okay? Now, if you have all this fluid, and it's normally 50 cc's, let's say you have 500 in there, half a liter, okay, 500 cc's. Do you think that the heart is going to be able to heart pump effectively? No, okay, essentially it's kind of getting drowned, right? It's drowning itself in that pericardial sac, okay? And so we said hypotension is one of the signs and symptoms. What else could be a sign and symptom? Tachycardia, yes! Remember guys, think about that formula. Remember, I was such a mean professor and I made you learn that formula. Cardiac output equals heart rate times stroke volume. Okay, if something is happening and there's a decrease in cardiac output, either the heart rate or the stroke volume is going to have to take charge and say, hey, I got you, let me help you. Okay, remember, within that equation of stroke volume, you have preload, afterload, and contractility. Currently, is stroke volume under attack with that contractility? You better freaking believe it, okay? Contractility is not happening when there's at 500 cc's, when there's 450 extra cc's in that pericardial sac. Okay, so the heart rate is going to say, yo, I got you. Let me help you. Okay, it's not going to do much, but it's going to try. So you could see tachycardia, 100%. Hypotension, okay? The patient is probably going to be complaining of maybe some dizziness. Maybe they're going to have a level of conscious changes. Things are not going to be going well for them, okay? Now, when, right, that complication happens, what is that called? What is that called when you have that 450 extra cc's and it is causing a decrease in cardiac output? What is it?
Cardiac tamponade.
Yes, exactly, cardiac tamponade. Perfect. That is one of the main complications you got to be worried about when you have pericarditis. You got to be on the lookout for it, okay? So let's do these questions and then we'll talk more about cardiac tamponade. All right, let's do 30 more seconds, then we'll talk about it. Guys, we are doing great on time. I'm so proud of us. We are on the right trajectory today. It's because I'm wearing my dance goes with the business casual clothes, that's why. Comfort is number one. I thought about wearing more fancy shoes, and I was like, why? Don't be dumb. You want to be comfortable. You gotta be walking around. You don't know how to walk in heels anymore. That's like not a thing. Okay, let's talk about this. So, a patient is hospitalized with chronic pericarditis. On assessment, you note the patient has pitting edema in the lower extremities, crackles in lungs, and dyspnea on exertion. The patient's echocardiogram shows thickening of the pericardium. This is known as what type of pericarditis? Okay, so let's rule out some things, okay? So, is this describing a pericardial effusion? No, right? A pericardial effusion is that abnormal accumulation of fluid in the pericardial sac. Have we mentioned that at all? No, okay? So, again, this is not a pericardial effusion, okay? Now, acute pericarditis, is that something that we're describing? No. No, why? Why are we not describing acute? What kinds of things alert you to it? Okay, first word, right? Chronic. The patient is hospitalized with chronic pericarditis. So essentially, they've been dealing with this for a long period of time, okay? Let's say that that wasn't even there, right? Let's say that that word wasn't there. I didn't give you that awesome clue. And then you look at the assessment. On assessment, you know the patient has pitting edema in the lower extremities, okay? What is that indicative of? Pitting edema in the lower extremities. What? Heart failure. Which side? Right or left? Right. Okay. Oh man. Crackles in the lungs. So Laura, she's trying to trick us. She's got some trickery up her sleeve. What is that indicative of? Left-sided heart failure. So right away, what can we say this patient is suffering from? Global heart failure. Right and left. Right? We got both. This patient is not doing so well. Okay? This patient is not doing so well. And then again, dyspnea on exertion, right? We've learned in the past, left-sided lungs, right? Not loser lungs, okay? Left-sided lungs, and then the peripheral edema in the lower extremities. So we can think to ourselves, this patient, it's a chronic problem, so much so that they have developed heart failure. That pump is really working against what they're having to deal with in that pericardium, okay? And then, whoa, we have more diagnostic data. Echocardiogram shows thickening of the pericardium. Is that a normal finding? Absolutely not. Okay, your pericardium should not be thickened, okay? So we look and we can say, right, that it's constrictive pericarditis. Okay, it's a type of pericarditis, it's constrictive. Okay, make it make sense, right? Make it make sense. The heart is having a hard time pumping. There's some constrictive things happening. What's constricted? The thickened pericardium, right? So, over a while, chronically, right, it has not been able to pump effectively, which is thus causing the heart failure. Does that make sense? It's not effusion, what does that say? Effusion constrictive? There's no mention of a large amount of fluid accumulation, right? An effusion is an accumulation of fluid. There's no mention of that, okay? In the echocardiogram, it should show us that there's that effusion, but there's no mention of that, okay? Questions? Okay. Isn't cardiac so fun, you guys? This is just the basis of the fun, toe in the pool of amazingness. I love it. I love cardiac. I used to hate it, and now I love it. I know this is going to inspire some people to work in CVICU. It's going to be the best. I love it. I'm not going to lie, guys. Every time I look by, I'm like, oh, they're here. They're here.
I've seen them downstairs.
I didn't come.
What did you say?
Well, we seen a whole group of people that was like moving in the
Okay.
middle of the library.
All right, well, let's hope that that's not our people, okay? Let's hope that that's not our people. No, it's gonna be fine. It's gonna be A-okay. You can just demonstrate how awesome we all are, you know?
They might postpone.
Who said they're gonna postpone? Oh, okay, I was like, really? I know, right? I was gonna say, I was like, okay. Okay, guys. You guys ready to answer this one? Yeah? Okay, good. You are providing care to a patient with pericarditis. Which of the following is not a proper nursing intervention for this patient? So not, they capitalized. Okay. Do we want to monitor for the patient for complications of cardiac tamponade?
Yes.
You better believe it, okay? You must be monitoring and be on the lookout for this. This, cardiac tamponade, medical emergency, worst case scenario, okay? Pericarditis, high risk to developing that. Do you want to administer ibuprofen as scheduled? Yes, right? That's gonna help the inflammation, 100%, okay? Place the patient in supine position to relieve the pain. No, right? Laying flat. You don't want them to lay flat. You want them sitting up as much as they can. Probably, honestly, getting them up to a chair, best case scenario, right? Like having them sit in a recliner at the bedside, okay? Like a little stand and pivot kind of situation. Not a lot of movement, not a lot of exertion. Obviously, all beds in the ICU, you can put them in a chair position. You absolutely could do that, but again, positional. Pericarditis is positional chest pain, okay? And then, do you want to monitor the patient for pulsus paradoxus and muffled heart tremors? Yes, because they're signs of what? Cardiac tamponade, absolutely, okay, absolutely. Okay. I love it. I love it. Be careful, right? Be careful when you read this. Read the question and the answers carefully. Okay. On physical assessment of a patient with pericarditis, you may hear what type of heart sound? Okay. Do we think it's S3 or S4? No, S3 is usually associated with heart failure, okay? S4 is aortic stenosis, okay? We're just talking about pericarditis. Mitral murmur, nope, definitely not. We don't have any of the valve issues right now, okay? Pleural friction rep, okay? You narrowed it down because you remember me saying, Professor Bloor, I remember you saying the hallmark sign is a friction rep, okay? Pleural is what? Where is that? The lungs. Okay? Absolutely not. It is not a pleural friction rep. You're looking at the pericardial friction rep. Okay? So again, different. Okay. So let's talk about the decompensation. This is your worst nightmare. It's maybe not your worst nightmare, but certainly bad things are going to happen. Okay? So decompensation occurs. The patient in the previous scenario develops a pericardial effusion, a large one. Okay, we've got maybe 500 to 600 extra cc's in there. And we develop cardiac tamponade. This is so sad for us. Uh-oh. Uh-oh. So, what are some signs and symptoms of cardiac tamponade? And then, what are you going to do about it? So take a couple minutes and let's type out the signs and symptoms of cardiac tamponade, and then what are you going to do about it? Promenade? I love that.
That word just makes me feel like.
Your heart's taking a promenade to stop it. That's, that's where it's going, doing.
She said hyper. And they said hyper.
Okay, so I see a lot of signs and symptoms. That's great. I love it. Oh, I see one medical management. Love it. Okay, so remember, this is that lady, right? That lady that she seems lovely. She's really sad that she has pericarditis, right? You walk in the room and she's fidgeting. She can't get comfortable, okay? She's super restless. You look up at the monitor and she was sinus rhythm, like 80s to 90s. Now she's tacking out in the 120s, 130s, okay? So she's restless, she's agitated, okay? She's tachycardic, okay? She looks a little bit more diaphoretic and pale than she did before. Uh-oh, that's not good, right? She is complaining maybe of some chest tightness. Okay, I see that there, chest tightness. And when she tries to get into the bed, the side of the bed, because she's like, man, maybe if I just sit on the side of the bed, it will make me feel better. She says that she's dizzy. Okay? So again, we need to be thinking cardiac tamponade, right? Again, all signs of low cardiac output, right? Low cardiac output. Now, I think you guys did it within here, okay? But I don't think anybody named it though. But in cardiac tamponade, some of the cardinal signs that you look for are Beck's triad. What are the things, 3 things with Beck's triad?
Jugular vein dysfunction.
JVD, okay, perfect. Why does that happen, do you think, Scarlett? Why does a JVD happen?
Because it's like a plug and the blood flow is going up.
Yes, I love it. Okay, so the heart, it's like a plug. Things are backing up, right? Forward flow is not working well, so things are backing up. So you'll see a huge bulge where their venous, or you'll see right where their IJ is, okay? Some venous dissension, okay? It's gonna be obvious. You're gonna be like, whoa, I did not see that before, okay? So JVD, what's the second thing?
Hypotension.
Okay, hypotension with a narrowed pulse pressure. Professor Blur, you're throwing some new words at us. I don't know what pulse pressure means. What are you trying to trick us? No trickery here. Pulse pressure, how you get that is a systolic minus diastolic. Okay, so it's hypotension with a narrowed pulse pressure. So what that means by looking at your A line is that your diastolic, or excuse me, your systolic and diastolic are very close. Like 82/70. It's pretty close, right? So you have a narrowed pulse pressure. You have hypotension, but narrowed pulse pressure, okay? So JVD, hypotension with narrowed pulse pressure. And then third thing, muffled heart tones, absolutely. You, in your previous assessment at 8 o'clock, you listened, because you're an astute nurse. As part of your head to toe assessment, you listened and you heard a wonderful S1, S2, loud and clear, loved up. Okay, now when you put your stethoscope there, you're not sure you hear anything, which is not great, okay? So with cardiac tamponade, these are the kinds of signs and symptoms that you're gonna see. Things are gonna be happening rapidly, okay? The decompensation, when they get to the cardiac tamponade of the heart not being able to contract appropriately, things start to happen quickly. So, besides clinically looking at the patient, how are we going to confirm that this is happening? What do you think? An echo. Oh gosh, it's 3 o'clock in the morning and the guy's at home. So he's not gonna be here for an hour, shoot. But we gotta wait. What? Okay, x-ray. Yes, an x-ray can absolutely be used as a diagnostic tool, 100%, okay? Also, most intensivists are trained, they're not gonna be able to get the clearest picture that a true echocardiogram would get, but they absolutely can put an ultrasound on the heart and look to see that there is fluid, okay? But an x-ray absolutely can work, okay? To be able to see that something is abnormal, okay? Now, what are we gonna do about it? I see it in here. Pericardiocentesis, okay? So essentially, are you gonna do this? You're gonna stick a needle in someone's heart? Absolutely not. Okay, this is a physician thing. Okay, they're going to stick a needle in there and aspirate fluid. Again, cardiac tamponade, medical emergency. Okay? Now, oftentimes, if someone has pericarditis, they have this pericardial effusion, so this accumulation of fluid around the heart that happens, okay, and we're still in the process of treating whatever the cause is of it, that infection, whatever, oftentimes it will reaccumulate, okay? So they may go and get a drain, okay, a pericardial drain to prevent someone developing cardiac tamponade again, okay? So your patient gets a drain, okay? We did it at the bedside, we did the needle, they went to IR, they got the drain, and the cardiologist who helped assist put it in says, hey, keep an eye on this, okay? And you're like, oh yeah, okay, got it down, just keep an eye on it. And he's like, hey, so, you know, I'm kind of worried about it clotting off, you know, because there's blood and stuff accumulating in there, that fluid. So I think maybe every, like, I don't know, whatever you think, like 2 to 3 hours, go ahead and aspirate off of that drain. And you're looking at him, and you're thinking about it, and you're like, hey, you need to do this. This is gonna save this patient, because if it clots off, they're gonna tamponade again, and they could cope. What do you guys think about that? Do you think that's within your scope of practice, to be able to aspirate off of a drain that's in someone's heart?
No.
Absolutely not, okay? Did a physician ask me to do that? You better believe it. Did he make me feel bad when I questioned him? You better believe it, okay? Again, physicians do not know your scope of practice, okay? They do not. They're gonna ask you to do anything and everything. You must know. You must say, you know what, I'm so sorry, I actually cannot do that. If you want to do that, you are more than welcome to come and aspirate off that pericardial drain. But I'm not doing anything like that, okay? That is not within your scope of practice. Could that happen? Could it clot off? Absolutely. Could that be a problem? You better believe it. But that is not within your scope of practice to do. You can alert them, hey, I'm worried. It stopped draining 2 hours ago. I was having steady output, and now that's not happening. That's a phone call. That's an SBAR phone call that you call a physician. But when they call you and they're like, hey, I'm at home, can you just aspirate on it? I don't think so. You call another physician, I've done that before, the intensivist, and said, hey, they're telling me to do this, I'm not doing it. It's not with my stroke practice. I worked real hard to get my license. I don't want to lose it. Okay? It's a real thing, you guys. People can lose their license. You do not want to do that. You have worked so hard, okay, to get here. You don't want to lose it. And please know that physicians do not know your scope of practice, okay? So we do the pericardiocentesis, we get that fluid off, they get a pericardial drain. What do we want to do with that fluid? Throw it away? Send it. Send it where?
To the lab.
To the lab. Why would I want to do that?
Testing.
Testing. Excellent. Okay, so test it. See what kind of microorganism is driving this, right, pericarditis, and then get the appropriate antibiotics, okay, absolutely. So important, okay? Is that a sample that you want to send in the tube station?
No.
You walk it down, or you have transport come and pick it up, right? These kind of really special, intricate, hard samples to get, you absolutely do not want to send it to the tube station. Because let me tell you, that one time you do it, they're gonna lose it. And the phone call to call your physician and say, hey, so remember when you did the pericardiocentesis and you drew out that fluid and then the needle's not in there anymore and they haven't gone for the drain yet? We lost it. They're not gonna be pleased, okay? So any sort of very important fluid, you want to make sure that you're either walking it down to lab or that transport is put in and that's being sent appropriately, okay? Because it's a conversation you do not want to have, okay? Questions, excuse me, about this. Oh, one thing that I didn't want to talk about, okay? People put this. Pulseless paradoxus. People love to say that. It's fun to say, right? Like cardiac tamponade, pulseless paradoxus, right? That's what they're showing. So what the heck does that mean? You put it, you best be able to describe what it is.
Pulses are different on each side?
No, that happens with aortic aneurysm.
It's a decrease in diastolic blood pressure, 10, later than 10.
Yes, that's
Really
it.
inspiration.
Yes, perfect. So it's a drop. It's a drop in the systolic. Okay, it's drop in the systolic. Okay, you'll see it. Now, if you are doing a cuff pressure, do you think you'll be able to see that? No. What type of situation would you like your patient to have to be able to see that drop in the systolic? Usually you're right, it's by 10 to 12, usually it's greater than 12 millimeters of mercury, and it happens during inspiration. So the patient takes a deep breath and you see that drop in systolic. That's pulseless paradoxus. Now, would you like an invasive or non-invasive blood pressure? Okay, good. So invasive, right? So think about that, guys, right? You have a waveform, a continuous waveform, beat to beat, A line, arterial line, right? We talked about that 500 years ago, first A together, right? I know you guys are like, whoa, that was a long time ago, Professor Blair. I don't remember that. Well, you better review because that's going to be on your test, right? So you have an arterial line. You can look up at the monitor. You can like, patient, look at the monitor, patient, monitor, right? And you see as they're taking inspirations, as they're taking breaths in, you can see the drop in the systolic, okay? It's very hard to catch when you're doing cuff pressures, okay? It's very hard to catch. But with an A line, you see it in real time, okay? So pulseless paradoxus, it's hard to see, but you will be able to see that drop in systolic. Usually it's greater than 12 millimeters of mercury, that drop. So, let's say it was 120, now it's minus whatever 12 is, okay, when they take a deep breath. So that is one of the signs that you'll see when they have that cardiac tamponade, okay? Questions about this? No? Okay, let's move on. Okay, next up. Whew, all these patients, look at craziness here on the unit. 6-year-old female patient is admitted to your floor. She's been complaining of a feeling of heartbeat in her stomach. She says when she lays down, there's a throbbing feeling in her abdomen. She's now complaining of back pain that is progressively getting worse. That's not good. Heart rate of 115, high, low, or normal? High, perfect, okay. Blood pressure of 85/40 with a MAP of 59. It's low, right? We do not like that MAP. We would love a MAP greater than 65, so we are worried at this point with end organ perfusion. Rest reserve 28. A little high, right? A little high. She is satting 95% on 2 liters nasal cannula, and her temp is 36.5. Is she febrile?
No.
Nope, she's normal thermic. Okay? So, what are we looking at? Given this patient's presentation, what do we think is going on? How can you confirm your diagnosis? Okay, so let's talk about this. So she described some weird symptoms, right? So she said that she had a complaining of a feeling of a heartbeat in her stomach. When she lays down, there's throbbing in her abdomen, and now she's complaining of back pain that is progressively getting worse, okay? So in that, you guys have to determine that it's an aortic aneurysm. I love it, okay? So real quick, aneurysms. What the heck are they?
A rupture in the artery.
It's like a balloon.
Okay, so it's not quite a rupture, okay? We're not quite there, but there is something wrong with the integrity, you're on the right track, of the artery, okay? What?
It's like a balloon.
Kind of, yeah, that's a great way to think about it. It's kind of like a balloon, okay? So it's, as you say, outpushing, right? If I had a whiteboard, I would draw it, right? I know you guys would all love that. But again, the integrity of the artery, right, is compromised, okay? Oftentimes you can see that there's like a sac or dilatation happening, and essentially what it is, it's a weak point in the wall of the artery, okay? So if you think about your aorta, right, your aorta is that huge artery that goes throughout your body, right? Aortic arch down into your thoracic cavity, into your abdominal region, right? It's huge, okay? Now, oftentimes the integrity of that wall can be compromised, okay? Saccular type of aneurysm is one side, where like one side bulges out, like you said, a balloon. I love that analogy, that's perfect, okay? And then fusiform is the whole thing, all sides, okay? So again, the integrity of the vessel is compromised. Down the road, disaster strikes, Alex, you're right, it can rupture. We absolutely don't want that to happen. We want to catch it before. Now, in thinking about what you know about vasculature, right? Thinking about what you know, what kinds of risk factors do you think that this patient might have if she's developed an aortic abdominal aneurysm? What do you think? So if the vasculature has been compromised, right? The lining of it, and we have a weak spot where like it's
A rupture?
okay, that can happen, yes. But think about what kinds of disease processes, activities, right, can cause the vasculature to not be as strong. Smoker, yes, absolutely. A smoker is a high risk. She is a smoker. 6-year-old, she smokes 5 packs a day, okay? And I put that in there, but yeah, she is. So smoker can impact the vasculature, okay? It can actually cause hypertension too, vasoconstriction. Another risk factor is hypertension, right? Think about it, right? That constant constriction happening can make the vasculature weak, okay? Now think about the actual vasculature. What kinds of plaques can form? It also can happen in the coronary arteries. We're going to talk about acute coronary syndrome later. What do you guys think? Atherosclerosis, yes, absolutely. So again, the most common cause is atherosclerosis. Okay, so again, think about anything that compromises the strength of that vasculature wall. Okay, that can lead to an aneurysm. Okay, huge risk factor, hypertension. Okay, so again, that lining of the vasculature, it's like a layer of it is compromised. It's causing a balloon, if you will, a balloon, okay? So we talked about her symptoms were in the abdomen, okay? So she said that she had a pulsating feeling in her abdomen, okay? And then she was complaining of low back pain, right? Now, if this patient is, let's say, 200 kilos, okay, do you think that you're going to be able to auscultate anything in her belly? Like a pulsating mass? No. Okay? So again, depending on the type of patient, you need to make sure that you are altering how you're assessing them. Now, let's say the patient's 40 kilos. Do you think you'll be able to auscultate that? 100%. You probably can stand at the doorway and see it, right? Because they're probably, what, 40 kilos is like 80 pounds, right? Okay. So real quick, how would these signs and symptoms of a AAA, abdominal aortic aneurysm, right, differ from, let's say, a thoracic thoracic aneurysm, aortic aneurysm. So think about, again, right, make it make sense. You're like, Professor Blair, you're talking a lot about symptomology, we just gotta move on, right? We have so much Nearpod to get through. Think about where it's at, right? Where it's at. So your this is your abdomen, right? Your thoracic cavity is up here, right? What kinds of other organs are up here? Your lungs, okay, what else? What's that big tube that you put food in? Your esophagus, okay? So depending on where it's at in your thoracic cavity can help you clue in what symptomology you may be encountering, right? So what kinds of symptoms do you think? Throw it out there. If you have an aneurysm in your thoracic cavity, how do you think the patient's gonna present?
Chest pain.
Okay, it could be chest pain. Okay, what else?
Describe as ripping or tearing.
What?
It could be describing the pain as ripping or tearing.
Okay, so that is more associated when it's dissecting. Okay, I like it. We're fast forwarding, but right now, thoracic aneurysm. So someone said chest pain or coughing. I don't think you said coughing, I just added that on.
Palpitations.
Palpitations, okay, perfect. What else?
Trouble swallowing.
Yes, trouble swallowing. So if you have some sort of compromised integrity of your vasculature near your esophagus, do you think that extra balloon could be pressing on the esophagus? Absolutely. So you could 100% have dysphagia. Absolutely. Shortness of breath, did we say that yet? Dyspnea, cough, okay? Difficulty speaking sometimes, depending on where it's at. So again, guys, you can have an aneurysm anywhere on your aorta, okay? Anywhere on your aorta, and that you will see the patients present differently, okay? Now, how you can confirm it, I see it here, CT, we always love our CT. That exam, I told you about the physical exam, obviously depending on how many kilos your patient is going to be able to differentiate if that physical exam is gonna work. But I mean, CT's key, just send them down for a CT. And then sometimes an ultrasound, and then sometimes they're gonna want a CTA, CT angio, okay? Where you shoot the dye in and you have a more clearer picture, okay? Questions about diagnosis and how you can confirm it? No? Okay, great. Dang it. It's like it freezes and then it doesn't want to work. Okay, so medical management. We already talked about how it can differ. I fast forwarded. Medical management and nursing interventions. What do you guys think? Oh, they could. Yeah, I like that. Good.
Or which one, the AAA or the TAA? Or both?
Both.
Control blood pressure.
Okay, so medical management. Now, oftentimes the patient could need surgery, right? What's usually the size where you're like, no, do not pass go, do not collect $200, you go into the OR? What's the size of that aneurysm where you're like, surgery?
5.5 centimeters.
Anything greater than 5.5 centimeters. Excellent, good job. Please make a note of that. 5.5 centimeters, the patient has a trip to the OR for a repairs, okay? Now, most of the time, if it's less than that, less than 5.5, okay, let's say it's 2, you are going to, everyone wrote it on there, or like the 5 of you, right? Blood pressure management. Blood pressure management is going to be huge, right? Why do you think blood pressure management is so big? Why do you think that?
More pressure on the bubble.
Yes, exactly. You don't want more pressure on that bubble. Why? Because it can dissect or rupture. You want to avoid that, okay? What do you think is worse, dissecting or rupturing? Rupturing. Rupture means there's an explosion happening. Dissecting means there's tearing happening. Okay? We absolutely do not want rupture. Rupture usually leads to death. Okay? We don't want that. So you want to make sure you have a blood pressure control. Now, looking back at our farm, right? Oh gosh, Professor Bloor, I thought I'd be down with that. Ha! No way. So, pharmacology. What kinds of drugs would you maybe anticipate? An antihypertensive. Name one. Okay, I heard Esmolol. Okay, it's a twofer, right? Esmolol is a twofer. You're going to lower that blood pressure, and the ones that are going to do your heart rate too. It's going to slow it down. Okay, great. I love it. So Esmolol could absolutely be it. What else? What else do you think? What? What is it? Metoprolol. Okay, so I love your thought process, but in this particular case, we want infusions. They could be on that in addition, PO, but when they are in acute, they came into the hospital, they're diagnosed with this AAA, we need an infusion that we can titrate, okay? So what other, Esmolol is an infusion, what other infusions do you anticipate?
Mag sulfate.
What is it?
Maybe mag sulfate.
Tell me about, why would you have mag sulfate?
Smooth muscle relaxer and calm everything down.
Okay, I mean, I think that that's possible, but I think that you want something more having to do with the vasculature. I see what your head is at, but I don't think mag sulfate would be something, a go-to that we would do for this particular thing. You see more mag sulfate in like pregnant people and relaxing that smooth muscle, okay? What's another antihypertensive? Specific antihypertensive going to lower your blood pressure.
Calcium channel blocker.
Yes, calcium channel blocker. I heard it. Nicardipine. Okay? Nicardipine. What'd you say?
Amiodarone.
Now amiodarone is going to be that antiarrhythmic. Okay, so an antiarrhythmic, so if your patient flips into AFib, 100% they're going to buy themselves an amiodarone infusion. Okay? So an antihypertensive, something that works on the blood pressure. Okay? So we've said Esmolol thus far. We've said Nicardipine. What's another one? What's another one? Has an N. Starts with an N. Nitroprusside. Absolutely. They can be on this, okay? The order that you will see to titrate this drip is usually keep the systolic between 120 and 140. Okay, that's tight parameters, you guys. Tight parameters. You may be having to titrate your drips frequently, okay? Frequently. So just know that this needs this. If the patient becomes hypertensive, it could lead to dissection or rupture. Okay? Pain, I love it. Pain medication. Perfect. Love it. That can also act as a twofer to keep your blood pressure down. Okay? So we talked about the blood pressure management before and after surgery, or just blood pressure management in general. If they go to surgery, oftentimes they're going to have what's called an endovascular repair. Okay? They need to be supine afterwards for at least 6 hours, okay? Usually you'll see an order after 2 hours, you can raise the head of the bed a little bit. Usually it's less than 30 to 45 degrees. The patient is going to be on bed rest, okay? Now, if they went in and they repaired and they went through the groin, okay? They went through the groin to repair the aorta in the abdomen, the AAA. What kinds of things do you need to be assessing on that leg? Pulse. Okay, so they went through the artery, right? So you want to assess the pulse. What other things do you want to assess besides the pulse? Capillary fill. Okay, bleeding. So at the site, you want to make sure that there's no hematoma. Okay. You said capillary fill, pulse. What else? What about temperature? Okay, warm.
Cold to the touch.
Okay, is it cold to the touch? Perfect. Okay. Color. Is it paler than the other leg? Okay. Now, if you look at where the femoral artery is, it's very close to a nerve. Okay? And so you want to make sure you're assessing what other things, what kinds of questions do you want to maybe be asking your patient? Numbness or tingling, absolutely. Okay? So you want to make sure, hey, how's your leg feeling? Are you experiencing any numbness and tingling? Can you feel me when I touch your leg? Can you feel me when I touch your toes? Okay? So what we call that assessment is a neurovascular assessment. Okay? So anytime they go in through any sort of femoral artery, we need to be worried about perfusion distally. Okay? So be thinking about, that's part of your nursing interventions. When they come back from the OR or IR, wherever they did the procedure, you need to make sure you are assessing for that. Okay? Now, they just did this endovascular repair, right? Where they went in the abdomen and they put some stents in, they repaired the vessels, and we know that they're at risk for bleeding, right? What kinds of things do you think that you should maybe tell your patient not to do to avoid the bleeding? What kinds of things do you think right here do we not want them doing? Straining, I love it. So you want them to have an easy bowel movement, no straining. Okay, what other things can increase the pressure in their abdomen? Heavy lifting, okay, perfect. What else?
Food that produces gas.
Okay, maybe, sure. Okay, what else?
Coffee.
Coughing, yes. Coughing and sneezing. Sneezing you can't really do much about. You just hope that they don't do it, right? But anything that increases the pressure in there, okay? Sneezing, coughing, throwing up, vomiting, right? Straining, okay? Because guys, let me tell you, that little stent or whatever they did in there to repair that vessel is tender, okay? Bad things can happen, okay? We need to make sure that we have good blood pressure control because we don't want to compromise that and cause bleeding, okay? Questions about this? No? Okay. Okay, so what are the signs and symptoms of a dissecting aorta? So what happens is when a dissection happens, okay, it doesn't mean immediate death, but it definitely is like a medical emergency, you best go in and figure it out, is that vessel, right, that diseased vessel from atherosclerosis starts to tear. And essentially blood gets caught in there and there's a false lumen that happens, okay? We don't want dissecting to happen. It can be caused by poorly controlled hypertension. We already talked about that, right? Cocaine is a big one. Cocaine messes with your vasculature. And then also someone can have a dissecting aorta with blood trauma. So they get into a car accident and you can see that they have a dissecting aorta, okay? So how do you think your patient's gonna present? What do you think they're gonna complain of? Nobody knows? Explain? Or is the internet stuck? Oh, there you go. Oh no, no answer, no answer. Severe chest and back pain. Excellent. Intense chest pain. Ripping. Didn't I just give you guys that answer? Ripping, right? So the aortic dissection is life-threatening, you guys. You must know that your patient is going to buy an immediate trip to surgery, okay? Usually the signs and symptoms, what someone says, is that there's severe persistent tearing. The pain feels like it's ripping or tearing, okay? And then this, Alex, is where you would have blood pressure is different in each arm. You take non-invasive blood pressure and you have difference in each arm, okay? So again, you can have someone that develops this dissection gradually, okay? Those are the people that are not taking their antihypertensives at home, okay? Where gradually you have some dissection. The acute people are the ones that maybe went on a binge of cocaine, right? And they just rip it. Or there's blood trauma that happens. Okay, irregardless, it's life-threatening and they must go to the OR to fix this, okay? Questions about aneurysms? Questions about different locations, what you do with it? When did they go to surgery? 5.5, greater than 5.5 centimeters. Okay, let's take a 5-minute break. Stand up, go to the bathroom, get something to drink, okay? And then let's come back at 11:25. Okay, we're almost done with this Nearpod. You guys got this. We're almost done.
You have that